My name is Krystal Waldrup, and I'm one of the nurse coordinators at Corewell Health William Beaumont University Hospital. And when bispecifics first came out, we were looking into some of the monitoring that is required and looking at some of our experiences that we had with CAR T and seeing that, yes, these same side effects can happen with bispecifics, but at a much lower rate. I know probably across the entire United States, it is difficult to get beds on oncology units. So anything that requires monitoring on an oncology unit takes away from another patient that needs really to be on that oncology unit. So when we looked at what bispecifics required, we saw, okay, this is really just we need nurses that are able to identify CRS and neurotoxicity so that they can get the proper treatment. So we decided instead we have a medical observation unit in our hospital, and we approached our medical observation unit to see, is this something that you guys think you could handle? And is this something that we could teach you? And they said yes. I was the same person who trained all of our nurses for CAR T, so I already really knew what worked and what didn't. So I kind of did very similar to what I did when I trained all of the nurses on our oncology unit on how to monitor CRS and neurotoxicities, but still breaking down even farther. I mean, every oncology patient, they have so much going on with them, but really breaking down to the easiest terminology that I possibly could for these observation nurses and just basically showing them this is what CRS is, this is what it looks like. It's going to look like sepsis, but making sure you're looking for CRS and looking at the neurotoxicities. Yes, it's probably not going to happen very often, but basically if you're getting that nurse's intuition that something's off with this patient, maybe we should be looking at neurotoxicity. So then we created tip sheets. So we already have tip sheets for our oncology unit for CAR T, so we kind of adapted them over to bispecifics, making sure that they had binders on the unit where they could easily find information on bispecifics. We have tip sheets on each of the different bispecifics that are out so that they can see the specifics of how often these side effects are going to happen, what different side effects happen with the different drugs, and basically just making ourselves available. Our NPs have been phenomenal. They always go and see the bispecifics patients when they're on the medical observation unit. So that has really helped the nurses because if they have questions or anything, they can go to our nurse practitioners and answer whatever they need. Our nurses, when I first started training them on bispecifics, basically the first thing I asked these nurses is, how often have you cared for cancer patients? And most of them were like, well, I've seen one or two, but really we're just waiting until we can get to the oncology unit. So I could tell that they were pretty nervous about oncology. I think anybody that is not around oncology always gets nervous when they hear the word cancer, but they embraced it. I will say they did a phenomenal job. As soon as I broke down CRS for them in easy, gave them all of the tip sheets, gave them all of the information, gave them the grading scales, they took it and they ran with it. And I will say they have done an absolutely phenomenal job. And I've seen a lot of the same mannerisms in these nurses that I see in oncology, because I know in oncology, you're so used to seeing these patients over and over and over again. You see them for cycle 1, cycle 2, cycle 3. So each time it's, oh, hey, how's the family? How's your daughter doing? All of that. And I was seeing the same thing happen in our medical observation unit nurses, which is such a great thing because, yeah, they see patients frequently, but like these are scheduled admissions where they get to say like, oh, your next dose is next Thursday. Oh, I'll be here that day so I can have you again. And they've been making these same relationships that I see in oncology, and that has been phenomenal. the using the grading scale. The grading scale is so nice. So using the grading scale is a great idea. And then also knowing that this is not going to work for every patient. I think we had to learn this as we go, or as we went and as we implemented it, is not every single patient is going to be appropriate for our medical observation unit. There's always going to be the one patient where there's something else going on with them, or their cancer is just more progressed than we would have liked. And our administration has been phenomenal as well in that aspect, and where if we tell them, I don't know, I think this patient really should be on our oncology unit for this ramp up period, and maybe we do like 2 doses on oncology, see how they do, and then go to the medical observation unit. Or we say, no, absolutely not. This patient needs to be on our oncology unit for the full ramp up. They're just too sick. And they've been completely okay with us doing that. So definitely knowing that you need to be aware that not every patient is going to be able to qualify for doing this, but knowing that nurses are nurses, and nurses can be trained, and nurses can do anything. We're actually hoping to use this as maybe our step towards going to outpatients with CAR T. I know it's a little off topic, but we're hoping that maybe because our medical observation unit nurses are getting more comfortable with the CRS, the neurotoxicity, we might be able to use this when we eventually go outpatient with CAR T. In that maybe if a patient's having some cytokine release syndrome in the outpatient, maybe all they need is some TOCI or just to be watched, we might be able to bring them to our medical observation unit because they already understand CRS, they already know what to look for. So maybe they can get those quick medications, be watched for a little bit, and go home, and again, not bog down our oncology unit. So that's hopefully our next step.